Good evening, my name is Colin Stone, and this is my presentation on amyotrophic lateral sclerosis. ALS is a progressive neurodegenerative disease that affects the nerve cells in the brain and the spinal cord, and it will lead to muscular atrophy in the body. It affects only motor neurons, so sensation will remain intact. After diagnosis, patient will typically survive about 3 to 5 years, and this disease is fatal. ALS is more commonly known as Lou Gehrig's disease, who is a famous Yankee player, and on the right I provided a link into his backstory. Approximately 6,000 new cases are diagnosed in the US every year, and there is no known cure. Now, the way that ALS attacks the body is that it targets all voluntary control. The way it does this is that it goes after two main components of the neurological system. First being the upper motor neurons, which relay information from the brain stem to the lower motor neurons, and that's the next component, which link the upper motor neurons to the skeletal muscles. This link is responsible for all muscle movement as it relays the contract and relax information from the brain directly to the skeletal muscle. So when this is disrupted, this will lead to muscular atrophy. The way that ALS disrupts these nerves is through axonal degeneration. So the motor axons will die off, attacking the larger motor units first, the larger muscle groups. And the way the axons die is that the Schwann cells of the axon will catabolize the myelin sheath, and then the axon will break apart into fragments. And this leads to muscular atrophy. As you can see on the diagram on the right, comparing a normal spinal neuron and a diseased spinal neuron, when the chain is disrupted, the muscle will atrophy, which is a direct result of ALS. So the cause of ALS is still unknown. It is a non-discriminatory disease, which means that no race, gender, people group are targeted. It seems pretty broad throughout. There are two types. The most common is sporadic ALS, about 90% of cases. And this is where one person in a family unit is diagnosed. There is no inherited factor. Whereas the other one, it will be familial ALS, a lot less common. This is where ALS may be inherited, and they believe it's through genetic mutation. I did provide a link there from 1997 studying this. The other possible cause would be environmental factors, which they're still considering. And one study I found that was interesting is that veterans of the Gulf War are actually showing a higher occurrence of ALS diagnosis. The progression, because ALS is a progressive disease, there will be a progression of symptoms throughout the diagnosis. So early on, typically before diagnosis, the muscle groups will be affected locally, not necessarily on a widespread scale. Muscles become weak and soft, and at times the patient will experience tight and spastic cramping and twitching. There'll be minor signs of atrophy in the affected muscle regions. There'll be fatigue, loss of coordination, poor balance, slurred speech. In the middle of the diagnosis, typically, or 1 to 3 years after the diagnosis, the middle of the progression, symptoms become a lot more widespread, and throughout, muscular paralysis will begin. Contractures appear, which in the joints around the unused muscles will become rigid and deformed, causing a lot of pain in that patient, and atrophy will increase. Typically later on in the progression of ALS, most if not all voluntary control is paralyzed, leading to the complete immobilization of the patient. Respiratory function is typically impaired at this time because the diaphragm and intercostal muscles are then targeted, and the cranial nerves become targeted as well, affecting the speech, eating, and drinking functions of the patient. Typically, the cause of death in ALS is respiratory failure. Now, diagnosing symptoms of ALS, the onset of ALS is considered what's called insidious, so it's very subtle in its development. And the way that doctors can definitively diagnose it is the coexisting symptoms of both upper motor neuron and lower motor neuron deterioration. This is a distinctive factor of ALS. One common symptom that a lot of patients will see in a neurological disease is what's called the pseudobulbar palsy or pseudobulbar effect. If you follow that link, there's a little bit more information on that, but essentially what it is uncontrolled bouts of laughter and crying. During a physical exam, the doctor will typically check for what's called the Babinski reflex, and this is a primitive reflex that will appear in ALS patients and young infants, and this shows the deterioration of upper motor neurons. There will be noticeable muscular atrophy first in the limbs. Gait abnormalities will appear, nasal speech, and then the most accurate diagnostic tool that doctors have is what's called electromyogram. I don't know if you can see this because my video's on there, but An EMG is essentially a device that monitors the electrical signals from a motor neuron to a skeletal muscle. So you can see the example I have there on the right of an ALS patient, their EMG. Treatment and management of ALS for the caregiver, their role is going to be very supportive. So their goal is to keep the patient as comfortable and as mobile as long as possible. Rilotec is the main drug that is used in treatment of ALS. You're just treating the symptoms here. If you follow that link under Rilotec, it's Rilosol is the pharmaceutical name. That's an animation showing how Rilosol affects the neurons. And basically what it does is that it prolongs survival by reducing the damage that's done there. Physical therapy can be used to reduce the pain from the contractures that I mentioned earlier. Exercise has been known to slow progression of ALS. This is a great thing as it will maintain the functions of daily living and will increase or maintain quality of life in the patient. Stem cell research is one more area of that they're looking into in treating ALS. Now, the effect of ALS on the exercise response is all due to, or it depends on how far along the ALS has progressed. Muscular strength and endurance will be affected earlier on and more widespread later on. Respiratory function is not affected until later on in the progression. Flexibility, range of motion, and balance are typically compromised earlier on as well. So this will all affect the exercise response. And one important note is that due to the exhaustive nature of ALS, any exercise or exercise testing should not be done to the point of fatigue or exhaustion in the patient, as this will actually amplify the symptoms. My case study, Ted is a 52-year-old man, has been diagnosed with ALS 9 months ago. He's experiencing trouble keeping his balance when walking or standing for an extended period of time. His overall strength is decreasing, and it's noticeably in his arms at this point. His breathing has not yet showed any signs of impairment. So that's good. So he's currently sedentary. He's a non-smoker. His BMI is 23. His blood pressure is 124/78. Heart rate 64. Fasting blood glucose is 89. And total cholesterol is 186. LDLs are 113 and HDLs are 48. Family history. The only notable history is that his father died at age 79 of a myocardial infarction. He shows no major signs or symptoms of cardiovascular, respiratory, or metabolic disease. So that puts my risk stratification of him at a moderate risk with 2 risk factors. His goals are to be able to maintain strength and flexibility so he might be able to complete household and daily activities, as well as keeping like a certain level of endurance and not just feel so tired all the time. And then to overall just to delay the effects, the onset of the ALS. So before approaching exercise testing, a few things to consider. Again, the patient should not be pushed to the point of fatigue. His balance and coordination will be compromised. That'll be something to be aware of for his safety. Respiratory function will be affected later on. So actually all the exercise prescription will have to be subjective to the progression of ALS. So that must be something that has to be kept in mind throughout the exercise program. So exercise testing, I'm going to assess his functionality as well as his overall fitness capacity. Again, submaximal testing because I don't want to push him to the point of fatigue. And due to his moderate risk level and at a submax test, there is no recommendation for supervision during this test. I would use to assess his aerobic capacity a submax A-strand ergometer test. So this is just a single stage submax test that I can estimate his VO2 max using his heart rate in a nomogram. If he's uncomfortable in this position, you can do a submax treadmill test as well. To assess his flexibility and range of motion, direct measurements, I would use either goniometer and or inclinometer measurements. This will give me a good representation or a good measurement of his range of motion. And then some indirect measurements, especially for his upper body because he's already experiencing issues with his arms. 2 ideas with shoulder circumduction tests and a back scratch test as well. So I can get a good idea of where he is and flexibility of those regions. So to assess his balance, I would again make a note of that spotting is very important as patients with ALS usually have their balance is impaired. So for their safety, have somebody there for spotting or you be there for spotting just for their safety. Good test would be a dynamic functional reach test, which is depicted on the right, and or a timed up and go test as well. Now, a timed 5-meter walk will be able to distinct any gait abnormalities the patient might have. Now, when assessing muscular fitness, again, got to keep in mind not to push to the point of fatigue. We could use estimation methods, and what this will do is keep the patient away from like getting close to like the 1 RM, which is a little bit dangerous for him. So I could use like a 6 RM testing and estimate his 1 RM from that. And I would keep him like a seated position in a seated pin selectorized weight machine. Avoid any free weights just for his safety. And then avoid overworking the upper body as well. Just if he's already having issues with the arms, I don't want to stress him to that point. Endurance testing. In endurance tests, you typically will push the client to fatigue. So this is something that has to be considered and really thought about before performing on a patient with ALS. But if you were to lowered workload, about 60%, and increased reps, or a curl up or crunch test to assess his muscular endurance. Now, for exercise prescription for his aerobic exercise, I would prescribe about 3 to 4 days a week, intensity of about 50 to 60% of his VO2 max, duration about 15 to 30 minute sessions, and then the mode, I would have him focus on stable, low intensity aerobic exercises, more gross muscle movement, and things like the stationary bike ergometer, treadmill with supports, and or a spotter. Just make sure he's safe. Swimming is also a great and safe full body exercise as well. For muscular fitness, I would like to focus on major muscle groups that he'd be using in his daily living as according to his goals. So for muscular strength, I would prescribe about 2 to 3 days a week. Intensity only 60 to 75% of the estimated 1 RM. We're not really trying to build anything here, just trying to maintain some strength. For his upper body, because he has issues, don't want to push that too hard. So either 1 to 2 sets of 6 to 8 reps. And his lower body, since he hasn't relayed any pain with the lower body, about 2 to 3 sets with 6 to 8 reps. Mode, again, I'll keep him seated, avoiding any free weights, either seated weight machines or resistance machines. For muscular endurance, if his body is feeling up to it, I would have him work out on a different day than muscular strength just to avoid overworking the muscles. About 2 to 3 days a week. Intensity 5 to 6 on a 0 to 10 RPE scale. Duration 1 to 2 5 to 10 minute sessions. And I would like him to use the arm ergometer if he can in seated position, just so he can maintain a certain level of muscular endurance in his arms while he still has it. And a rowing machine would be great for full body endurance. Range of motion and balance exercise. I want to focus on muscles that are involved in keeping the center of gravity and posture. And for this, you have to make sure that the patient is safe and is spotted or given available support. Frequency about 2 to 4 days a week. Intensity for dynamic about to the full range of motion, and static stretching to the point of mild discomfort. For duration, 2 to 3 reps per pose or movement for 10 to 20 minutes. For static stretching, about 15 to 30 seconds hold for 2 to 3 reps per muscle group. The mode, involving as many muscle groups as he can, and I like stationary postural exercises such as Tai Chi, Pilates, yoga, and static stretching. This will help him keep his flexibility. So adaptations, due to the progressive nature of ALS, as I mentioned earlier, the program is going to have to be modified according to where he's progressing, where his symptoms are worsening. So intensity and duration can be lowered and will probably have to be lowered due to the impairment. The modes might have to change because he might not be able to do a certain movement later on. And then inevitably, ALS patients are typically bedridden towards the end, but their flexibility and range of motion can still be exercised by a physical therapist. And I did provide a link showing a physical therapist going through range of motion exercises with their client. So in conclusion, ALS is an insidious progressive disease that increasingly debilitates normal functions of everyday living. Exercise can help impede the progression of ALS, and it allows for longer survival of the patient and just overall quality of life. The patient with ALS, though, should not exercise to the point of fatigue, as this is going to amplify their symptoms and pain, and exercise must be modified to the progression of the disease. Above, I provided 2 links to 2 organizations that are doing a lot of work raising awareness for ALS and research and treatment. So it'll be something to consider checking out. And here are all my references. All right, thank you.